This patient is a 64-year-old female with symptomatic paroxysmal atrial fibrillation who failed flecainide therapy and desired an atrial fibrillation ablation. A pre-procedural cardiac CT, with an image seen here from a PA view, was completed to assess pulmonary vein anatomy. This patient has 2 left-sided pulmonary veins and 3 right-sided veins, including a right middle pulmonary vein. Informed consent is obtained while discussing the plan for the procedure as well as the risks involved. The patient is brought into the electrophysiology laboratory, and defibrillation patches, grounding pads, ECG leads, blood pressure cuff, oxygen saturation monitor, and 3-dimensional mapping system patches are applied. Conscious sedation, or in this case, general anesthesia, may be used as determined by physician and patient preference. A pre-procedural transesophageal echocardiogram is completed to rule out left atrial thrombus. When the cardiac rhythm at the start of the procedure is atrial fibrillation, evaluation for atrial thrombus is mandatory. In patients with paroxysmal atrial fibrillation and sinus rhythm, TEE is frequently performed, but is not mandatory, depending on physician preference and the specific clinical circumstances. The patient is then prepped in the standard fashion. Here we are entering only from the femoral vein, so the bilateral groins are prepped, though some operators may choose to access the internal jugular or subclavian veins as well. After prepping the areas for venous access, sterile draping is applied. The operator performs a sterile scrub and dons a sterile gown and gloves. The equipment needed for the procedure should be immediately available, including a local anesthetic, such as lidocaine, with needles and syringes, introducer sheaths of varying sizes with sterile tubing, transeptal needle, intracardiac echo equipment, catheters and associated cables, recording system and pacing stimulator, fluoroscopy. A 3-dimensional mapping system is required to optimally guide the procedure and ensure procedural success. If merging with the CT is to be completed, as seen here, initial processing is completed. To obtain venous access, first feel for the femoral artery, which then identifies the location of the femoral vein about 1 centimeter medial to the artery. Local anesthetic over the femoral vein is given at this point. After adequate local anesthesia has been achieved, the femoral vein is accessed using the modified Seldinger technique. Ultrasound guidance may be desired for venous access because it allows entering only the anterior wall of the vessel, reducing the likelihood of post-procedural hematoma. A wire is placed through the needle once there is blood return. A second venous access point is obtained in the femoral vein, about 3 to 5 millimeters away from the first location. Venous access is then similarly obtained in the contralateral femoral vein. After the wires are placed in the veins, the sheaths are inserted over the wires. Once venous access is obtained, the electrophysiology catheters are inserted through the sheaths. Under fluoroscopy, a multipolar catheter is maneuvered into the coronary sinus. An intracardiac echocardiography, or ICE, catheter is placed through a venous sheath and advanced using fluoroscopy into the right atrium. A view of the interatrial septum, seen by the thick arrow above, with the left pulmonary veins, seen by the thinner arrows below, is obtained. Once the anatomy has been visualized for the transeptal puncture, a guide wire is advanced through one of the femoral venous sheaths into the superior vena cava to about the level of the carina of the trachea. The introducer sheath is removed. A transeptal sheath and dilator are advanced over the wire up to the superior vena cava. The guide wire is removed and the dilator is flushed with heparinized saline. The ICE catheter is maneuvered into the right ventricle to assess for pericardial fluid, then pulled back into the right atrium to visualize the interatrial septum again. The transeptal needle is advanced into the dilator and sheath assembly, with the needle oriented at about 4 o'clock. The tip of the needle is kept about 1 centimeter back from the end of the dilator. The needle should be attached to a transducer to measure the intraatrial pressures, and an optimal view of the septum is found using ICE. The sheath assembly is then pulled down to the fossa ovalis. The needle is advanced until it enters the left atrium. Once the needle is across the septum, a left atrial pressure tracing is seen. Alternatively, the needle may be flushed with saline so that microbubbles are visualized in the left atrium on the ICE images. The sheath and dilator are then advanced into the left atrium with the needle in a fixed position. The sheath is then advanced over the dilator. The needle and dilator are carefully removed, and the sheath is aspirated and flushed with heparinized saline. A continuous heparinized saline infusion is then given through the sheath. This process is repeated for a second transeptal puncture. The second sheath is advanced into the left atrium in a similar manner. The ICE catheter is again advanced into the right ventricle to reassess for the presence of pericardial fluid. Heparin bolus and infusion may be given prior to or after the transeptal puncture to maintain an ACT of at least 300. Once access to the left atrium has been achieved, the ablation catheter is advanced through a transeptal sheath and placed in the left atrium. A circular catheter is inserted through the other transeptal sheath. It is placed into one of the pulmonary veins. Here it is in the left superior pulmonary vein. The ablation catheter is then maneuvered around the left atrium to make a 3-dimensional anatomic map of the chamber. The orange marks where the catheter actually was in space, and the gray is an approximation of the left atrial surface. Care is taken to delineate each of the pulmonary veins, specifically noting any early branches and the location of the ostia. Here, the ablation catheter is maneuvered into the right superior pulmonary vein. The right inferior pulmonary vein is found below it. It is sometimes easier to maneuver without the orange showing. The 3D map of the left atrium is made by moving catheter around the chamber in this manner. The map can be rotated around for different views. Here, in a left lateral view, the anatomy and location of the left atrial appendage is well marked. The mitral valve location should also be marked. In addition to using the electrograms on the recording system, creating a mitral valve helps determine when the catheter has inadvertently entered the left ventricle. The image was merged with the CT scan with the electroanatomic map on the left and the CT image on the right. Each of the pulmonary veins, including the right middle pulmonary vein, is color-coded, as seen here from the end of the case after ablation lesions were completed. Barium is injected into an oral gastric tube and the image is saved on fluoroscopy. This delineates the location of the esophagus, which should be avoided during the ablation. Some operators may use an esophageal temperature probe or esophageal catheter instead. There are several approaches to atrial fibrillation ablation. A wide area circumferential ablation with pulmonary vein isolation is shown here, using an open irrigated catheter at 35 watts, but decreased to 30 watts on the posterior wall. Each red dot represents an ablation point, completely encircling the left and right sets of pulmonary veins. The left set of veins is ablated first. Here, the catheter is in the ridge between the left atrial appendage, seen in red, and the left inferior pulmonary vein, seen in brown. point-by-point ablation is performed circumferentially around the left set of pulmonary veins. The catheter is now just below the left inferior pulmonary vein. The catheter is placed on the left atrial wall adjacent to, but not within, the pulmonary vein ostium to avoid pulmonary vein stenosis. Here the left veins are almost completely encircled, and a gap in the posterior wall is being filled in. Care is taken to avoid ablating near the esophagus, or to use lower power in these locations. After the left set of veins is isolated, the right set of veins is then addressed. The circular mapping catheter has been moved to the right superior vein, seen here in purple, and ablation lesions have been performed to encircle the entire right set of veins. A gap on the posterior wall outside the right superior vein is filled in. This patient is in atrial fibrillation, and a direct current cardioversion was performed to convert back to normal sinus rhythm. The electrograms on the circular catheter, denoted LS, are then examined to look for any residual pulmonary vein potentials in each of the veins. These are high-frequency signals, marked by the white arrow, usually seen after the far-field atrial signal, marked by the yellow arrow. If present, the vein is not isolated and further ablation lesions are needed. Sometimes the pulmonary vein potential, seen by the white arrow, is very delayed compared to the far-field left atrial potential, seen by the yellow arrow. The location of the earliest pulmonary vein potential is found, seen here on LS 19 and 20, and ablation is performed near this bipole to eliminate the signal. This is repeated until there is entrance block, where there is absence of pulmonary vein potentials on the entire circular catheter, seen here on the second beat. Exit block is then determined. Pacing at high amplitude is completed from each of the bipoles on the circular catheter. There should be absence of capture of the atrium with pulmonary vein pacing. This will be best seen by discordance between the rate of the pacing stimulus, with the white arrows, and the atrial electrogram on the coronary sinus catheter, with the yellow arrows. Local capture of the pulmonary vein may be seen, with pulmonary vein potentials present on several bipoles following pacing from LS 19 and 20, which does not capture the rest of the heart. This is a sign the vein is isolated. If there is capture from a bipole, where a pacing stimulus advances the rate on the coronary sinus catheter and the surface ECG, the vein is not isolated, and ablation lesions are placed near these bipoles. The goal of the procedure is the absence of pulmonary vein electrograms on the circular catheter and inability to capture the atrium when pacing from within the pulmonary vein. Once entrance and exit block are achieved in this vein, the same process of achieving and confirming entrance and exit block is completed for all the other pulmonary veins. Isoproterenol infusion is then given, starting at 2 micrograms per minute and up to a maximum of 20 micrograms per minute, to induce sinus tachycardia and premature atrial contractions, or PACs. All PACs, especially those that initiate atrial fibrillation, should be assessed and possibly mapped and ablated. After the isoproterenol is stopped, exit and entrance block is reassessed in each vein. Some operators may also choose to give adenosine boluses to assess for electrical reconnection of the pulmonary veins. The catheters are withdrawn into the right atrium and the heparin infusion is stopped. The ICE catheter is again used to scan for pericardial effusion. If there is a history of spontaneous or induced typical atrial flutter, a cavo-tricuspid isthmus ablation line should be completed. The catheters are removed from the body. The long sheaths are exchanged over a wire for short sheaths, which are left in place until the ACT decreases. Alternatively, some operators give protamine to reverse the heparin effect. The sheaths can then be removed with manual hemostasis obtained. All cables and drapes are removed from the patient. The patient is then transferred to a stretcher. It is important not to bend the legs for 4 to 6 hours after sheath removal to prevent the development of hematoma. The procedure is then complete.